There are two parts in this webinar. There are two panel discussions. And Dr. Srishti Jain, who is the young and dynamic intensivist from MGIMS Jaipur, a very prestigious institute running a very, very busy department. She will be our scientific coordinator and the timekeeper for the evening. Over to you, Dr. Srishti.
Thank you so much, sir, for inviting me. It feels really glad to be a part of this evening where ISCCM and ISOT, that is our organization of organ transplantation, we are organizing this webinar on organ donation and transplantation. So I would like to invite Dr. Ranveer Tyagi, sir, to give a welcome note and address. Thank you, sir. Over to you.
Namaste to all. First of all, as we all know, Athithi Deva was, so first of all, I invite to President Ma'am Arpita Rai, President of ISOT, Dr. Manish, and Vice President Dr. Ravi, and other Dr. Amol and the classes. And our ISCCM President, Dr. Srinivas Samavidam, and past President, Dr. R.K. Mani, Dr. Pradeep Bhattacharya, and Dr. Kapil Jipre, and Dr. Josh Chako. So we all know the organ donation is the biggest donation in the earth. Like Nar Seva, Narayan Seva. So these are two things which are biggest. So, but the lack of awareness is still in the society. That is the challenge. So if both society together create awareness, that will be better. So now, without taking much time, I would like to hand over mic to Srishti. Please go ahead. Because some internet problem also, I am traveling from Kedarnath to Haridwar. So that is
Wow.
the issue. Thank you.
Wow, sir. Thank you so much, sir, for the warm welcome. And I'm sure your blessings from Kedarnath are here with us as well today. So thank you so much. We'll now start with our first panel discussion, and I would like to invite Dr. Riaz Javeri, sir, to moderate this session. I would also request you, sir, to kindly introduce our esteemed panelists to our audience. Thank you.
Thank you, Dr. Srishti. Thank you, Dr. Ravi Tyagi. I'd like to invite my esteemed panelists for the first discussion. The first discussion is about maintenance of brain dead patients and relevance to organ transplant outcomes. Our panelists are Dr. Srinivas Samvedam, a very dear friend and the president of ISCCM. Welcome, Dr. Srinivas. Dr. Arpita Rai Chaudhary, Madam is Professor Nephrology at IIT Kolkata, and she is very active in organ donation programs across the country. Welcome, Madam. Dr. Josh Chaiko, a teacher to many of us, and he's a very senior intensivist from Bangalore and a very, very active teacher.
Thanks.
Physical as well as an online. Now he is a very active online teacher as well. Dr. Mani, my teacher, my ex-boss and my mentor, and he has been the past president of ISCCN. And Dr. Ravi Mohanka. Dr. Ravi Mohanka is a leading liver transplant and hepatobiliary surgeon at HN Reliance Hospital, Mumbai. Welcome, Dr. Ravi. So without much ado, I'll start the discussion. My first question is to Dr. Srinivas. Why should be brain dead or potentially brain dead patients be identified early? Is it only for organ donation or also for declaration of death?
Okay. Thank you, Dr. Yash, and thank you for inviting me and having me on this panel discussion. And a good evening to all my co-panelists, my teachers, and my mentors. There are three answers to the question you asked. One, as intensivists, it is not only enough for us to be looking at life-saving interventions and therapies, but it is also our responsibility to ensure that we do not overdo or apply intensive care principles to the situations where the individual in question will not have meaningful outcomes from their perspective. It is a responsibility. The second aspect is, of course, for resource utilization. How do you manage your resources? If you don't identify these patients early, the potential organ donors early, the golden period has passed. Now, this patient cannot just be kept in the ICU just as a part of the existence of the ICU. You need to look after the patient, and you have lost the opportunity of saving several more lives. That is the second reason why we should be looking at it. Of course, the third reason is that we are in need for potentially life-saving organs. And the last one is everybody deserves a dignified death. Everybody, irrespective of where you are, which setup you are working in, and what is your socio-economic status. You deserve, it's your right to die in a dignified manner. And as providers of care for patients who are more likely to die, intensivists have that onus on us to ensure that no patient suffers the ignominy of an undignified or indignified death. These are the four answers I have.
Thank you, Dr. Srinivas, for putting it very, very comprehensively. My next question is to Dr. Jose, sir. How to rule out confounders with absolute certainty, especially if we talk about toxins, medications, ECMO, and hypothermia?
Yeah, that's a very important question, Yash.
Sir.
You cannot, the diagnosis of brain death may not be straightforward all the time, although we have stringent criteria, which is described in the TOTA Act as such. At times, you have to resort to these ancillary modalities of diagnosis, which would include patients with a background of heavy dose sedation, overdosage, electrolyte abnormalities, particularly high sodium level, primary neurological problems which can mimic brain death. In fact, I remember a patient with organophosphorus poisoning who looked like brain dead, but in fact was not really brain dead. And locked-in syndrome. There are several conditions, neurological conditions and otherwise, which would lead to the ostensibly looks like brain death, but it really isn't. And then when there is a doubt, you can't go by the usual tests alone. And that's when the ancillary techniques come into play. And the methods that we have available usually include, particularly in our setting, we do a CT angiogram to demonstrate no flow to the brain. But then you could do transcranial Doppler, which is readily available by the bedside. I do it very often. One of the problems with transcranial Doppler is that you need to see and follow up the patient in a regular fashion. Otherwise, purely because there is a lack of window, you might not see blood flow, and that cannot be cannot be attributed to brain death purely because the bone window is poor. So if in a patient you see good flows to begin with, and then it disappears over time, that is a very, very definitive indicator that your patient is likely to be brain dead. And then, of course, there are typical waveform abnormalities, including the tall, spiky waveforms that you get initially, and then the diastolic reversal. All these are very typical. So these can also be considered one of the ancillary techniques. And then, of course, the scintigram, which we don't often do, but it's another technique where you demonstrate an empty skull syndrome. So these are some of the ancillary methodologies that you can use when there is sufficient ambiguity regarding the diagnosis of brain death. But of course, I'm not entirely sure, perhaps Dr. Mani can highlight, to what extent are we expected to rely on these ancillary techniques, particularly in the Indian setting?
Thank you, sir. Thank you for elucidating the confounders and the need for ancillary tests. My follow-up question is to Dr. Mani. What is the legal standing of these ancillary tests, and when do we do these tests and when not?
See, as far as the TOA is concerned, it doesn't mandate any ancillary. In fact, it only mandates apnea testing. So ancillary tests come in when there are serious questions about confounders, or apnea testing fails, for one reason or the other. There is instability, hemodynamic instability, or it is it is ambiguous. It doesn't meet the targets, target levels of PCO2. So in those circumstances, you do the ancillary test, and this is what the THOA tells you, that you don't. It's not mandatory, but it's an option to be considered collectively by the brain death committee. Okay, if there is consensus, there is no surety amongst the amongst the brain death committee at the end of an aborted or actual apnea testing, then you may do the ancillary test. And as Joe said that, there are those options. Each one has, the gold standard is a DSA, 4-vessel DSA. And CT angiogram and MR angiogram are, also to be considered. And then, of course, the transcranial Doppler with its caveats. And the centigram is also very reliable. It can be done, SPECT. So I think legally speaking, the apnea test has the gold standard.
Yeah.
Is the only thing that's required, apart from the clinical.
Thank you, sir. Thank you for explaining it very nicely. My next question is to Dr. Arpita, madam.
Yes.
What are the legal aspects of brain death declaration, especially in medical legal cases like head injury?
Yes. So for this legal aspect, we need for medical legal cases, this stands as a problem because they are usually delayed, because we need the involvement of the forensic medicine department, which is very much a part of an academic institute. But many times the usual commercial hospitals, they might not have this facility of FSM opinion to be taken, their persons to be around the dissection when the organ retrieval is happening. Actually, the police has to be informed. The local police sometimes is not the only police, because the accident takes place somewhere distant, and from there a mail should reach the local police station stating the exact situation, how the accident occurred, and one official from the local police station should be there during organ retrieval. And we have to have a forensic medicine person during retrieval. In West Bengal, we address this problem by attaching the nearest teaching hospitals FSM department to cater the service to the hospital nearby. But sometimes this may become a problem, and the patient might have to be sent to the mortuary again for the second dissection for this FSM opinion. To address this, we have made this decision. We sat with the FSM people, and they are helpful enough to be around the retrieval session whenever the retrieval takes place, even in the middle of the night.
Thank you, madam. Very important point. See, medical legal cases, especially trauma-related road traffic accidents or toxins, these are no barriers towards brain death donation, but the police has to be intimated and the body has to be handed over after organ retrieval to the police. We move on to the next question. Dr. Ravi, very important question. What is the impact of preservation of a brain dead donor and the quality of organs you get?
Oh, thank you very much for this invitation and this question. So the impact is huge. So the thing is that the graft outcome, the outcome of success of the transplanted organ and the success of the survival of the transplanted patient, the recipient, depends on the quality of the organ. While there are standard criteria for each organ for assessing its function, for liver, its liver function tests, for creatinine and urine output for the kidneys, and similarly echo for the heart, or angiography for the heart, and for bronchoscopy and imaging for the lungs. But if there is any ischemic injury to the organ, because there were episodes of hypotension, there were episodes of cardiac arrest or hypoxia during CPR. So those are not really captured always in these tests. And therefore, if the tests, organ-specific tests are even normal, but the organ could have suffered ischemic injury. In sometimes when you do a biopsy on the liver or on the kidney, you will see necrosis on that. And it may not result in a very big difference to the LFT initially, because it takes time for them to get abnormal and then recover from that. So a donor whose blood pressure, oxygen levels have been maintained very well, they will generally not have any ischemic, any effect of on the outcome of the recipient. On similar principles, if there is a donor who's fluid overloaded, then it will affect the lungs, cause pulmonary edema, and that can also affect the function of the lungs. So apart from the standard testing that we do, if a donor is well maintained, then they will have excellent outcomes generally. And these are the things to keep in mind. So good oxygenation, good blood pressure, and not a lot of fluid overload. With these three things, we can get very good outcomes from organs that are transplanted from such donors.
Thank you, Dr. Ravi. So this is a very important point for intensive especially. We have to learn the art and science of preserving potential organ donors. So if a patient is potentially brain dead or a potential donor, we have to put everything in to preserve the patient and the organs also in best possible way. The further discussion will be based on these findings. Another important question is, I'll put this question to Dr. Pitara, madam. We'll go in a reverse order now. When should the transplant coordinator come into picture?
Yeah.
At some centers, they call them very early, which I find it grossly wrong. So what is the right time?
So when you identify a patient of GCS below 5 in the intensive care unit, so the first intimation should go to the transplant coordinator. He may not appear in his own role, but
Yeah.
he appears as a facilitator to build up the rapport with the family who is waiting there, going through the trauma of the situation, the grief, as well as the grief has started that he is getting the bad news continuously, has to run for blood here and there. Particularly in the government hospital, everything is not at the tip of your hand. You have to run to the blood bank, you have to run to this corner for the medicine, this corner for the blood bank. And then I usually call my transplant coordinator at this point of time. I asked them to reach. Initially, when I built up the system, there was a lot of role mixing. I didn't always stick to my role that I should not be there till not my team will be there. So I instructed my coordinators to be there from very beginning, like when the conversation starts that your patient is not doing well, he shows up his face or she shows up her face, that they're a friend in the situation. They build up the rapport. So they build up the rapport so that later on, when they will put the request, they will be someone who was helping them out. The in ICCU physician introduces them as a part of the team of patient care in the hospital, not by the name that organ transplant coordinator. Their name is uttered much later when first brain death is declared, and then the immediate grief is over and the organ donation request is made. But by that time, they have grown a little friendship, offering tea, sitting beside, tapping, putting a glass of water in front. All these friendly jobs they can do, and also can help in government setup to sort out with all the medicine, blood, and things are required.
Thank you. So till the time the patient has not been declared brain dead, they remain behind the curtains.
Yes.
Once the declaration is made, they take their role. Meanwhile, once we are preparing for the declaration, they start doing their bit of things and they do the processes for organ
Rapport building and all.
Thank you, madam. My next question will be to Dr. Mani, sir. What will be a stepwise communication after brain death declaration or from the point of brain death declaration?
For me,
Yes, sir.
yeah, okay. After brain death declaration, once the initiation has been made by the coordinator, talking about organ donation, and if the family is showing inclination, then the intensivist and the primary, physician or neurologist should participate in the communication. So communication obviously has to be unambiguous and sensitive. Why I'm saying unambiguous is, see, brain death has to be conveyed very clearly as death. That is one hurdle which we don't seem to be overcoming very often. In most places, I mean, brain death, the equivalence of brain death and death is not conveyed with conviction. Okay, even professionals are somehow ambiguous about it, although since 1969 in the world, this is very clear. So conveying the certainty of death, is extremely important in communication, extremely important in converting to a potential organ donor, because there's a lot of lack of conversion. And then emphasizing the altruistic aspect, okay, how others benefit, how there is always that altruistic aspect latent in the human being, and that has to be brought out, and that has to be emphasized, not just the mechanism of how to do it, but the human side has to be at length talked about, and then allowing uh, um, expression of feelings, expression of emotion, allowing questions. The patient sensitivity is so important because of the emotions involved, and so communication is most effective tool here. Intervention in this conversion to a potential organ donor for brain dead individual.
Thank you, sir. And we have to remember that we cannot abandon the patient in life or in death. Even once we have declared the patient brain dead, we should not abandon the patient or the family. We have to maintain the connect with them. Moving on to the next question to Dr. Srinivas. What is it's a long question? Probably you have to give a concise answer. What will be a critical pathway for sequential tasks in deceased organ donation process? What will be the sequence like?
You mean the donation process?
Yeah.
Okay. So it depends on how your local system is organized. For example, in the south, in at least in Telangana, Andhra, Tamil Nadu, the Jivandan Trust plays a very significant role in channelizing, allocating, and facilitating these processes. So when the primary identification of a potential donor is made, while the hospital administration and the in-house transplant coordinator is alerted, it is our responsibility to alert the local Jivandan coordinator. The in-house team does not broach the prospects of a donation till the Jivandan coordinator has a chat with the family. That's the first process. Then our medical steps in certifying the two tests and then the certification of brain death happens. At the same time, there is a counseling that goes on with the family. Then our medical processes of sustaining the organs, identifying the potential recipients, and alerting the concerned retrieval centers or the concerned teams for availability of a potential organ set is made, and the process of mobilizing this patient happens. There are two categories of hospitals that are existing in the current healthcare ecosystem. Hospitals which are certified for brain death declaration, but not organ transplant centers, and hospitals which are both. So in the hospitals, the preference is usually given to the at least some the according to the list that the Jivandan facilitates. But in some situations where the hospital is not a transplant center. The in-house team takes the responsibility of transferring the patient to the nearest hospital which has the capability for the transplant. As has been already mentioned by Madam, the medico-legal cases are a little bit cumbersome in overcoming the challenges which are related in, suppose the police stations from where you are transferring the patient to the hospital, to a hospital where the police PS is different. The local team has to coordinate with the local police station and intimate them that such a potential medico-legal case is being transferred from our facility to another facility in the jurisdiction of another police station. So these are some of the logistic challenges which are, apart from the medical aspects, these are some of the challenges we face in the management of these patients.
Thank you. So these are the sequential steps for deceased organ donation. The last step which the IACCM guidelines mention is the adverse effects to recipients are informed to SOTO within 7 days of transplantation. But we as intensivists are rather unaware of these effects, side effects, or adverse effects. So I'll put this question to Dr. Ravi Mohanka again. We talk about this last step in the protocol,
Yes.
that adverse effects to recipients are informed to SOTO. What are those common adverse effects in your practice which you see need to be informed? Because this is we are lacking because we do not come into picture after this.
Yeah, so basically, we are talking about the adverse effects of organ
To the recipient,
the
yeah.
recipient, right? So
Yeah.
basically, sir, if depending, some of them are immediate and some of them are long term. So, for example, there may be a situation where the organ has suffered a lot of ischemic injury, and the organ may not function at all. That is primary non-function. And while in kidney, it will lead to patient going back on dialysis, but in other organs like liver or heart or lungs, it may be life-threatening and may only be corrected by a retransplant. So that is the extreme end of the spectrum, but that is fortunately very rare. Only in about less than 2% patients you see primary non-function. So, but the more likely situation, which will happen in about 20% or so patients, is what is called as delayed graft function in kidneys, where the patient may require dialysis in the first week, but after that their kidneys will start functioning. In liver, what is called as early graft dysfunction, which means that their bilirubin will go up, their graft may struggle a little, but ultimately they will probably have some ascites, the INR will go up, and then in about a couple of weeks, 2-3 weeks, their liver functions will regenerate back, like liver will regenerate and functions will be fine. And then patients who have donors who are donation after circulatory death, not brain death, they may have a higher risk of biliary injury and biliary complication. But currently we don't practice that, and this session is not for that purpose, so we'll not discuss those. And heart and lungs, again, the primary non-function and the delayed graft function equivalents are there. So in most situations, in about 80% of cases, we won't find any of these. In about less than 2% cases, around 2%, you will get serious complications from these in the recipient, and in about 20%, you will get reversible problems which can happen.
Thank you, Dr. Ravi. Now we'll go on to the physiological targets for maintenance of an organ donation patient. My first question is Dr. Jose Chaku. So what are the hemodynamic goals and what vasopressor to use? It will be like rapid fire now, sir.
Yes, the most common problem that we encounter in brain death is that there is an initial catecholamine storm, high blood pressures, but that's usually transient, and then you get a vasodilatory state with hypotension. So at that stage, you need support. Noradrenaline may be appropriate. There are people who suggest the use of vasopressin in this situation because it has got the effect of supplementing the loss of vasopressin levels due to pituitary malfunction as well. So you need to maintain a mean arterial pressure roughly of about 70 millimeters of mercury, as you would do otherwise. I must say there is no strong evidence behind all these things. It's difficult to study all this, but still, what you do normally in your critically ill patient, you continue to do in your brain dead donor as well. Second is the respiratory support. Tidal volumes of 6 mils per kilogram is recommended. If you use higher tidal volumes, the lungs may get injured, as we know, and that might affect the graft survival and graft sustenance rates. And please do not use excessive fluid as well, which can cause accumulation in the lung that might affect the quality of the lung as well. Hypernatremia is avoided as best as possible by early use of vasopressin or desmopressin, and because the liver grafts function poorly. It's been shown to function poorly in the presence of hypernatremia. Then, of course, the hormonal changes that we see. We've already mentioned vasopressin. Second is the depletion of hydrocortisone, which is not common, but there are some who recommend routine use of methylpred in a dose of up to 1 grams per day, per 24 hours, that is. Thyroid function occasionally may be depleted as well, mainly because of the sick euthyroid syndrome, wherein the T4 gets converted to reverse T3. This usually doesn't require supplementation, but occasionally it might do so as well. So these are some of the important parameters that you go by. There is a rule of 100, which I read just the other day. Keep the heart, the blood pressure, systolic blood pressure of 100, blood sugar 100% of normal all the time, hemoglobin of 100 grams per liter, which is 10 grams percent, and the PO2 roughly 100. So these are the goals, roughly the ballpark numbers that have been recommended.
Thank you, sir. So we have to check the basic care, homeostasis, euvolemia, right vasopressors, the ventilation and oxygenation goals essentially remain same. We have to be aware of arrhythmias and treat them aggressively. Autonomic storm has to be addressed early. Nutrition, early nutrition, a hematocrit target of 30, temperature management, and infection prevention and management. So thank you, panelists, for elaborating on important legal as well as clinical aspects of brain death donation and preservation of the donor patients. And thank you, respected faculty. We move on to the second part. Over to Dr. Srishti, 1 minute before time.
Thank you.
That's
Yash, for a nice moderation.
Thank you, madam. Thank you.
Thank you. Thank you.
Thank you so much to Dr. Yash for moderating such an interesting discussion, and to all our panelists for such insightful inputs. We have one interesting question which Dr. Srinivas has answered already, but then I would still like to put it up there, that after declaring brain death, next process cost is paid by hospital or family. Now, Srinivas sir has already answered this, that billing stops after declaration. Big questions come that when we ask the family that we need to optimize the patient, and when we have in our minds that this patient can be a potential organ donor. So when we need all those ABGs and sometimes arterial lines and all those 2 days of, maybe 1 day or 2 day of optimization. So that becomes an ambiguous part. So what should be the ethical way to deal with the costs of declaration?
Yeah, just one comment. I think Dr. Mani will handle this question very nicely. See, money should not come into picture anywhere, even if the patient, the brain death, after declaration, if the patient is, the hospital is taking care of the patient, that again becomes a conflict of interest. Although the Indian documents and the Indian guidelines and most of the Western guidelines also suggest the same. I'll put this question to Dr. Mani now.
You know, there is a provision in the new rules that the cost of maintaining the potential donor will be borne by the recipient hospitals. Okay, the organ recipient hospitals. There is a provision, and they will pay to the SOTO, and SOTO will reimburse you. So this provision is there, and we should utilize it. But many times there is a third-party payment, and third-party, it is included in third-party payment, is maintenance costs. I think, as far as I know, I've
But sir,
seen it spelled out.
the finances coming in, I see it as a conflict of interest somehow, always.
Yeah.
No, conflict of
Very
interest
important
is
for Dr.
there.
Srinivas and others.
Yeah, conflict of
No,
interest is there for 2
yes.
reasons.
So,
Ah.
yeah.
Yeah, one thing is
So,
if there
yes.
is, yeah.
Yeah.
Yes, sir. Please
No,
go on, sir.
what I wanted to complete was that there is a cost to everything, and there has to be some ascription of who is going to bear the cost, you see. So there is a provision for that. It's not that, cost shouldn't be emphasized, but it's not unimportant. You have got to know where it comes from.
Yeah.
I feel
Yeah,
that
so
I feel the donor family should not be penalized for maintenance
Yes.
of
Yeah.
donor support.
yeah. So yes, when you say conflict of interest, it is if a recipient hospital pays a donor hospital, then it becomes a direct conflict of interest and a breach of identity, neutral approach to organ transplant. That is the reason why the organ transplant authority has taken the responsibility of, facilitating a financial conduit so that a potential organ donor is not subjected to suboptimal care, and therefore we end up with marginal organs. So this what you're saying is exactly the reason why the SOTO has stepped in and say we will collect and we will disperse. So the paying hospital and the receiving hospital do not know who is paying whom.
Yes.
That further clarifies. Thank you.
Absolutely.
Yes. Thank you so much, sir, for clarifying on this important ethical topic. And again, we don't find it everywhere. There are ambiguous zones in organ donation. Right. With this, we will thank our esteemed
Thank
panelists
you.
of the first session,
Thanks a
and we'll
lot.
move on to the next part of
Thank
our
you, madam.
webinar.
Thank you, sir.
For the second topic, the topic is role of intensivists and transplant physicians in donation after cardiac death. Another very interesting topic. And to moderate this, I would like to invite Dr. Amol Bhavne. And I would request Dr. Amol to take over from here and invite the panelists of our second discussion. Over to Dr. Amol. Thank you.
Thank you, Srijan ma'am, and thank you, S. Jawahari sir. You have made my work little bit easy now. So now I am Dr. Amol Bhavane, Assistant Professor, Department of Nephrology from AIIMS Nagpur. So let's move towards some specific things like donation after circulatory deaths, from more generalized theme of organ donation to the more specific themes. It is indeed important in the today's world where the availability of the organ is very less and need is much high. India's donation is less than 1 per million population, and we need for self-sufficiency to more than 50 per million population. So long ways to go. So somewhere we have to stretch the donor pool, and that's where the DCD come. So we are all aware that there are some barriers in the organ transplantations, and we need to breach that barriers. So if we see, we are exactly opposite what Western world is doing, where the deceased donor transplantation is more, and in India, more than 90% transplant, as you all know, is from the live donations. Deceased donation is less than around 10 to 15%, and that too DCD is a little minuscule. It is like a 1 or 2 or 3 transplant 1 year. But as such, DCD is not new to the India. It is way back in 1999, first DCD done in IKDRC Ahmedabad. Then Dr. Ashish Sharma take over, and 2011, Sir is the flag bearer and pioneer in the DCD transplantation at PGIM at Chandigarh. Recently, our institution has done 8 DCD at AIIMS Nagpur. So very few institutions is doing the DCD. Our need is to scale it up. It is not possible with this rate to fulfill this big gap. And another, to move toward the more sustainable way of doing the DCD, that is a controlled DCD, in light of recent Supreme Court judgment. So let's brainstorm, let's find solutions, and let's discuss with our very eminent and prestigious faculties who are pioneer in this field. So I would like to welcome Dr. Arpita Ray Chaudhary, ma'am. Ma'am is a president of Indian Society of Organ Transplantation, senior nephrologists and transplant physicians with outstanding contribution to the transplant medicine in India. Dr. Ashish Sharma sir is a professor and head Department of Renal Transplant Surgery, PGIM Chandigarh, a pioneer and flag bearer in DCD transplantation in India and inspiration for many of us working in this field. Dr. Kapil Jirpe sir is the head and senior consultant, Department of Neurocritical Care, Ruby Hall Clinic, Pune. And we all know sir is a national leader in the deceased donor maintenance and breast tender declarations and critical care. Dr. Pradeep Kumar Bhattacharya, sir. Sir is a professor and head trauma, emergency, and critical care surgeon at STEAM Institute of RIMS, Ranchi, and past president of Indian Society of Critical Care Medicine. I welcome you all dignitaries, and let's start brainstorming. So my first questions, without wasting time, my first question to the Dr. Arpita Are Chaudhary, ma'am, is that, ma'am, India currently sees only few DCD transplantation annually. You can count on the finger, largely limited to the few centers. With a shrinking pool of living donors, how can we strategically scale up the DCD donation to bridge the gap in the organ availability? Ma'am.
Actually, in India, as you have just rightly mentioned, that living donor pool is not shrinking, but living donor pool is not able to address the huge gap. And living donor pool is also expanding, swap is coming in, and still there will be lot of gap which need to be bridged up, and DCD is an important area. It is important because circulatory death is well accepted and well perceived over ages by lay people as well as even our colleagues. So with the recent Supreme Court judgment of and ICCM work on the withdrawal of life support, the dying with dignity, and there was a meeting of the CT forum people that who assembled to take this decision, that dignity, death with dignity is also an need or right of us. So all these things can prepare people's mind in a way that they are more easily counseled, agrees for organ donation. So that is one important area. And working in a public sector, I have felt that while we were waiting for DCD, long time on ventilator, counseling, controlled deaths either after DBD, Maastricht 4, or even before DBD, withdrawing support, all will save time and save the ventilators, which may serve others' purpose as well. And I think with NRP, the quality of organs also can improve in a way that we can convince people that this is the way. We can show UK as example, that in UK, the DCD is scaling up, and not that the kidneys are suffering a lot of delayed graft function. Thank you.
Thank you, ma'am, for your enlightening and such an elaborate answers. Thank you very much. Now there is a concern about outcomes, and who knows the better than Dr. Ashish Sharma, sir. Sir, based on your experience, how do the outcomes of DCD graft compare to those from the DBD donors, particularly in the context of the India's logistic constraint and limited organ preservation infrastructure? And additionally, sir, could you share any particular challenging or noteworthy DCD case you encounter in your practice and which is transformed into the successful story? Please, sir.
Yeah, so outcomes in general, if you talk at the international level, they are marginally better, if not same, as compared to DBD, because there is a selection bias that you would select young patients. You would probably reject the older or with more comorbidities. So outcomes in general are better. In Indian context, the long-term outcomes, our long-term outcomes have been great. The only concern is the immediate DGF, and that you have to jelify that the patient will be there in the hospital getting dialysis for 3 weeks. But once that period is taken care of, if you manage your immunosuppression well, and I think that takes care. If you talk about interesting cases, I think 2 cases I remember. The first case, 1 kidney never got. So that was a big handicap. And to take the program further, next 3 years we couldn't do this DCD donation again. Well, it's a nightmare for you and as well for the patient, for having undergone everything and the transplant, the financial aspect, and then you land up having a graft infectomy. The second case, I mean, from that to scaling up to a case where we had a patient who was brain dead but was not getting declared. His BP went low to less than 50, stayed at that level for next 7 hours. I mean, the urine output was still there, so we thought the kidney is probably getting perfused at level of less than 50 also. Fortunately, at that time, we had the preservation equipment, we had the normothermic perfusion. So we took the kidney out, put the kidney on the machine. We didn't have the dare to test the other kidney. We had only one equipment. So we used that kidney and the kidney worked, and that recipient is now more than 6 years. So I think so from non-working to, to a very extended, highly extended criteria kidney we could take. So
Thank you, sir. And always these stories inspire us to move forward. Basically, the story of from being non-working kidneys to the working kidney perfectly, which move us forward. So with this, my next question is for Dr. Kapil Jirpe, sir. Sir, in the light of Supreme Court recent judgment of 2023, simplifying the process for advanced medical directive and withdrawal of life support, how do you pursue the role of intensivist in initiating end-of-life care protocol, especially in the context of DCD donors and other way also? Additionally, how ethically and how legally secure in this process in the Indian context?
Thanks, Ashish. First thing I want to tell everyone that DCD is not a replacement for the organ donation for the brainstem death. We need to work a lot on our organ donation rate after the brain death. It is just now 1 per million. So it moved from 0.8 to 1. And we should aim for 15 to 16 to 20 per million. So our entire at present concentration on effort should be to increase the organ donation rates in India after the brain death. That is the first thing. Second thing, DCD is an add-on. DCD should not be the find to be filling the gap. It should be the add-on to the your brainstem death. So if we move with this concept, then possibly we may able to reduce that huge gap in between the demand and availability. Because what madam said very nicely, that the living organ donation rate is increasing, and they are now adding the SOP, which will add into the further. But still, if you want to reduce that huge gap, you need to have a brainstem death as well as the DCD go hand in hand. So first thing, we all should not replace the DCD for this thing, which will be defeat our program, which will straightway defeat our entire organ donation program. Second thing regarding the DCD, after the advance will in 2023 and 2024, there is a Supreme Court accepted the end of life procedure. But let me tell you, it is not still practically possible on the ground. There are certain, still we are facing the issues in terms of getting the health secretary's final approval for continuing. So in spite of the January 2024 Supreme Court judgment into mid 2025, still there are very few DCDs are happening. So this is in terms of the legal and ethical. So it is absolute legal and ethical in a critical care or ICU to follow the DCD. Now, if you see in entire this organ donation domain, that means I'm talking about the brain death and the DCD is a intensivist domain. I always say that the intensivist should be in the driving seat, because they are the one who are managing the donors. They are the one, they are managing the patients. I will not say now donors. I will say they are the patients, my patients, your patients, our patients. We are attaching with the families. So it's easy for intensivists to follow from a day one such patients with the help of the advanced will as well as with the help of the family communication, and we can make it routine in our ICUs, but it's a long standing process. But in current situation, DCD is possible in India. There is legal support is to the DCD. There are the laws are in favor of the DCD. Only we need to remove those last hiccups, and probably it will might be the very regular phenomena. Then DCD, we need to again say intensive, we should concentrate on the class 3 and class 4. That means it is the control, and both are the control this thing, so that we can have some quality of the organs which we can offer it to our poor recipients.
Thank you, sir. You rightly say all things should be go hand in hand, and everything should be a complementary to the each other. Should be each other, not the replacement. So very well said, sir. So my next question is to Dr. Pradeep Kumar Bhattacharya, sir. Sir, in trauma, you are the head and in charge of the trauma and emergency center at your institute. Sir, in trauma and emergency department, where cardiac arrests are frequent, how can intensivists identify and respond to the potential DCD opportunities in timely and ethical manner, sir?
Thank you for the question. Thank you for inviting me for this webinar. So, as you know, that for any new things to start, we need to see four important things. One is the structure, the process, the manpower, and all these things finally gives a better outcome if you have that thing. So every hospital, whomsoever is looking for DCG, should have a clear, well-defined DCD policies, which will address the identification criteria, the consent process. Then, when we talk about withdrawal of life support procedures, then death determination, then organ recovery logistics, all those things we need to have in hand. And these protocol should be developed in collaborations with all, not only intensivists, but also emergency physicians, the surgeon, all involved in organ donation and transplantation, and also the ethical as well as legal counsel. Very, very important. And the first and foremost, as I see, is that training. And what for training we give, that everyone who is working should be enough competent to identify the early recognition, that intensivists should be efficient at recognizing when the patient's injuries are catastrophic and inconsistent with survival. Then the another important thing is that they should, because everything, time is very, very important in this situation. So intensivists should be very clear and compassionate as far as communication with the family is concerned. And as far as withdrawal of life support, they must be able to independently define, and they should be able to develop a customized protocol with proper discussion with organ transplantation team. Then also you must explore that if the patient has given some previous wishes or so something like that, because this time is very, very crucial. So that everything, if it is done in a short period of time, around 60 to 90 minutes, then it will give a better outcome. So intensivist in collaboration with those organ donation team and organ retrieval team, they need to like they should develop this time, how they can manage this time frame so that they can provide the best outcome for the patient. And as soon as they come out with all these things, they immediately inform the SOTO so that organ retrieval, organ transplantation can also be done to that center where it is required, or if it is available with the same center, it can be done immediately. And the most important part, which as an emergency physician or intensivist face, is the medical management one, because donation after circulatory death is important. Why? The circulatory arrest, you need to maintain the oxygenation and perfusion of the organs which you want to retrieve. So this timings are very important. And then other important things that family counseling and family need to understand all these things in short period of time. So informed consent, how to get it, and for that appropriate training should be given to those who are involved with this. Emotional support is very, very important at this point of time, because they get less time to get accustomed to these things. Then for reducing this warm ischemia time, we need to have gadgets, which in the newer gadgets which has come, like normothermic regional perfusion, that is NRP, which just now we are talking. If we have those things, then we can always do the things in a much better way. For uncontrolled DCDs in emergency settings, we need to have a separate protocol where there is a refractory arrest, cardiac arrest happens, and most of the time out of the hospital arrests. So these all these things say that if you have a very good dedicated team which is specialized only on this particular purpose, definitely it will give a very good number of organs as well as the need of the society as well as outcome. And finally, I would not step out without saying that audit of DCD is very important. That will help because lots of ethical issues can arise. So to see these compliances, you need to have a good audit system in your hospital. So I think these are the things which are very, very important when we talk about DCDs.
Thank you, sir, for such a elaborate and detailed answer. And now I would again come with for Dr. Arpita Rai Chaudhary, ma'am. Ma'am, there is a noticeable hesitancy. One problem is that it doesn't happening at that much level. Another problem is that regarding the acceptance regarding the DCD kidneys, many time and allocation group there is a lot of hesitancy among physician, among surgeon, among different stakeholder, among in the also in the allocation group there is hesitancy for allocation also. So, ma'am, how do we address this problem and how do we overcome these issues?
This will, I think this will stay long, because even in Western world, where the awareness is there that organs mostly will come from deceased people, still extended criteria organs are refused and wasted till date quite a lot. So not at all that our country, where living donation, even a good number of unethical donations, live donations are happening, and people are getting organs that way, at least kidneys. So there will be hesitancy around it to accept an extended or criteria donor or extended criteria organ, marginal organ. The hesitancy will be there. Only showcasing a good outcome, educating people again and again that staying in wait list is no way better than getting a kidney from the marginal kidney, getting a marginal kidney and doing well without dialysis, at least for some years, when again you may find yourself eligible as recipient of another deceased kidney. This happens in Western world, and showcasing the results, trying the best to give our results, and what Dr. Bhattacharya was saying, audit not only about the legal procedures and audit about the outcome. And I feel some institutions may be identified who host a good number of good transplant surgeons who take up the difficult cases. Like in UK, I have seen the centers who only do obese recipients. Similarly, the institutes who are best at doing the complicated surgeries, like receiving a marginal organ, maintaining that organ, can be promoted, and people may enlist, willing people may enlist for those institutes, that even if getting a DCD organ, I will be happy to get an organ. That awareness has to be spread in the society. And society doesn't mean laymen only. To the medical society, your fraternity is most averse to accept any marginal organ.
Thank you, ma'am. You rightly said every organ is precious. Organ should not go the waste. Organ should not go waste, because that is the theme and that should be the motto. Generally, we try to accept marginal kidney also, thinking that it will change the life or it will transform the life of someone. Similarly, the DCD kidney also need to be accepted, need to be taught about. So, with the same line, I want to ask the question to Dr. Ashish Sharma, sir. Sir, there are key surgical and operational challenges in uncontrolled DCD, and how can India move toward implementing controlled DCDs in a practical way, sir?
So I think some of the challenges already highlighted,
Yes, sir.
graft dysfunction happening, dialysis. So the problem is that our physicians have become too choosy. They want best outcomes after the transplant. They're not accepting any delayed graft functions. And the second reason is that you have easy availability of unrelated transplants. So So that is the second handicap. And the third is that the government institutes are not doing these type of donations as well as transplants. And in private sector, this becomes a big handicap. Keeping a patient in hospital for 3 weeks is a big bill. So these are the challenges. I think some of these can be overcome by having more investment in organ preservation system like normothermic regional perfusion or normothermic organ perfusion. And as far as controlled donation is concerned, I think we should not be talking about donation. We should be probably talking of end of life. Have the protocols to implement withdrawal of life care in end of life situations. Once those things happen as a matter of routine, then the organ donation should be seen as a byproduct to it, not as a primary motive, right? We should not be starting withdrawal of life care to get organs. We should be promoting end of life and withdrawal of life support to give a dignity to death, right?
Thank you, sir. You rightly said we should organ donation and withdrawal of life should be dealing, and there should not be any conflict about that. Sir, now next question I want to ask to Dr. Kapil Jirpe, sir. Sir, you are the working in the DCD, DPD patient maintenance and the brainstem death declaration. So similarly, what modifications are needed in the ICU protocol to help identify and prepare a DCD donor? And how can we develop some uniform nationwide protocol for DCD maintenance and identification?
See, Dr. Ashish has mentioned very nicely, we should not see the end of life as a DCD source. So you need to change the entire mentality of the team working in ICU. First thing, all teams should gear up to implement the end of life policy in their ICUs. So first thing, if your intentions are good, your results are good. If the family should not feel that, and that's what happens with the branded donation, family should not feel that we are compromising certain things to get something. So first thing, all critical care fraternity in India should now start implementing the end of life as a routine. It should happen during the rounds. It should happen during the morning rounds when you are taking the grand round with your all entire staff and the doctors and discuss, is this a candidate for the end of life policy? Discuss very transparently and honestly with the families. Have the protocol there, which are the patients fitting into the end of life policy, like advanced will as well as the medical criteria. Practice it. First, practice it, the Indian implementation of the end of life policies in ICU. Once your entire unit and your staff and your administrations are settled with this, and you have started declaring and doing this, practicing this end of life, then move towards the DCD. Then it will become your routine. It should not be the specifically targeted with that there is a huge demand and the administration is behind that we need some more donations, and then you started implementing. No, I don't think so. What happened? Only thing good thing happened is over a period of the 1 year and 1.5 years, there is a good discussion as well as the awareness happened in India regarding the end of life. So now everybody is aware about this terminology. Majority of us are aware about the policy, like there should be the committee 1, committee 2, and then inform to the magistrate and go ahead with the steps. So steps are well laid down. Now only once the government is in a final stage of approval, we can start practicing it. And once we are in a practicing, it's easily done. So protocol is very simple. You let down the protocol for your end of life policy, which is a 10 steps and the 3 committee. Your job is done.
Sir, in the same, additionally, I want to ask one supplementary question to you, sir, Kapil sir. Sir, forget about the donations. So what is the stopping us to implementing these policy? What are the barriers you think?
Yeah, see now almost since last more than 6 months, my entire policy is ready. It is approved by the legal team and the administration and the CEO. The issue is the committee 1 is not a problem. The 2 guys are from the same hospital, and third is also from the same hospital. Second committee is also not the problem. 2 guys are from your hospital, and 1 is deputed by the DHO, but it may be from your hospital. The issue is that that DHO is not, they are not pro in implementing it. we need not need any permission from the magistrate. After the two committee approval, within 96 hours is the upper limit. You can do it within 24 hours also, both things. You need to only inform to the magistrate the last step. You did not, no need to take a permission. Problem is the first committee is not a problem. Second committee, the third person who should be appointed by the DHO is issue at present, because Supreme Court had laid down the entire process, except that legally every state government is now aware about that. The state government has to inform the health secretary, that he inform to the all DHOs that you need to cooperate. There, where I think that is a process where we are at present in a final stage. It will happen at any time. But you know the interest. It moves from state to state. Unfortunately, few states are proactive and they are already implemented. Few states are even not willing to discuss and not ready to give a time to even listen to that. And one of them is my state. Sorry to say.
Thank you, sir. You rightly point out the what are the problems and what are the solutions, sir. Sir, with the same, I would like to ask Dr. Pradeep Kumar Bhattacharya, sir. Sir, in DCD, we are mostly doing an uncontrolled DCD. Whatever happenings is because we are trying to tap the opportunity where we are not able to do a apnea test. Mostly this is happening. So, sir, we are only utilizing kidneys from this DCD donor. To utilize other organ, we need a good, better perfusion method and perfusion practices. Sir, what are the present scenario in India? Which perfusion methods we can use, and what is the current status of that perfusion method present in India?
Okay, so if you look at the oldest method which we are using and which is used in almost all the places is the that is static cold storage system, where we put the organ at 4 degree, typically 4 degree degree centigrade, and that reduces the warm ischemic time, and we try to retrieve the organ as fast as possible. But SCS has significant limitations. When we talk about liver, heart, lungs, and other important organs, then from DCD donors on this methodology, it doesn't fit for those things, because we fail to reduce this warm ischemia time with this. Then the important modifications which has happened recently are these, which although we are far behind what is happening in Western world, but some new thing has come, like hypothermic machine perfusion. So that is called HMP. This HMP for kidney has become more common in advanced transplant centers in India. And while its application for other organs like liver and heart is less widespread, but some leading institutions, I think they are exploring, or some of them might have started adopting this process. The most important one is this NRP, that is normothermic regional perfusion, where, it was discussed that this is a in situ technique which involves restoring the circulation of the organs with the help of extracorporeal membrane machine. And we can very well perfuse this abdominal as well as thoracic organs with the help of this machine. And NRP is a more advanced technique that but it require good infrastructure and highly trained personals. And we also need to follow the strict ethical protocol to do this. And as just now, Dr. Ashish said that they are using it in PGI Chandigarh. And as far as my knowledge goes, it is also used in IKDRC Ahmedabad. And they are performing this DCDs with the help of these machines. But I don't see there is any clear-cut guideline from NOTO as far as use of this NRP is concerned. Then NRP has become a game changer, definitely for multi-organ utilization, especially for liver, heart, and lung. Then there are some machines, they are providing this ex situ perfusion, or they are also called as organ care systems, they involve the removing the organs from the donor and then perfusing it in ex situ outside the body on a specialized machine. And the organs are kept hypothermic or in normothermic temperature. And this is another advancement which has happened, and it is also being used at many centers. Currently, I don't know exactly if some center in India they are using it or not. So these are the things which are new as far as maintaining the organ perfusion and oxygenation is concerned after retrieval. So I think this is what, in brief, what I can say at this point of time.
Thank you. I think I already exceed some time but then this discussion and this brainstorming which it give us a hope to move forward and give us a hope regarding patients. If we could save some organs from getting waste, and some could transfer some lives, that will also be important. If you have permissions, I would like to show a 1-minute video so that we could sum up it in a good tone and a good yeah. So I request that as a social media team to just start that video with the experience of the recipients, so that we can get motivated from our patient also. So that's the point.
क्या हो गया?
The video. Is there any problem, ma'am?
Play this video, please.
नहीं काम कर रहा है. I think we should
Should
move.
I try it from my end, ma'am?
Yeah, please.
मैं अनूप आनंद को जो
Are you able to?
मैं 4 साल 3 महीने से डायलिसिस करा रहा था. जो मुझे पता चला एम्स नागपुर हॉस्पिटल में कैडेवर किडनी का नंबर लगाया जाता है, तो मैंने नंबर लगाया. मैं इसलिए नंबर लगाया क्योंकि मुझे मेरे परिवार से किडनी देने के लिए कोई भी नहीं था. फिर मुझे 6 मार्च 2025 को कॉल आता है कि कैडेवर किडनी अवेलेबल है. हृदय गति बंद होने के कारण एक पेशेंट की किडनी अवेलेबल है. फिर मैंने सभी घर वालों से निर्णय लिया. फिर मैं 6 तारीख को हॉस्पिटल में आके एडमिट हुआ. 7 तारीख को मेरा ट्रांसप्लांट हुआ और ट्रांसप्लांट बड़ी अच्छी तरह से होगा. मैं अभी स्वस्थ हूँ, ना मुझे डायलिसिस की आवश्यकता है, मैं डायलिसिस फ्री हूँ और मैं अभी एक नॉर्मल लाइफ जी रहा हूँ. थैंक यू. मेरा किडनी ट्रांसप्लांट 3 दिसंबर 2023 को एम्स नागपुर में हुआ था. उसके पहले मेरा डायलिसिस 11 महीने से शुरू था. जब एम्स नागपुर में किडनी ट्रांसप्लांट की फैसिलिटी स्टार्ट हुई तो मैंने कैडेवर में अपना रजिस्ट्रेशन करवाया था. साथ ही साथ मेरे बड़े भाई मुझे किडनी देने चाह रहे थे, तो उनका भी फिटनेस एम्स नागपुर में शुरू था. बट किन्हीं कारणवश वो मुझे किडनी नहीं दे पाए क्योंकि उन्हें स्वास्थ्य संबंधी समस्या निकल आई थी. इसके बाद एम्स नागपुर के से कॉल आया था कि एक किडनी अवेलेबल है, लेकिन उनकी जो डोनर थे उनका हृदय गति रुक चुका है, तो उसके कारण थोड़ा जोखिम तो रहेगा ट्रांसप्लांट में. तो ऐसा मुझे एम्स के डॉक्टर्स ने और जो कोऑर्डिनेशन टीम थी उन्होंने मुझे समझाया था और मेरी फैमिली को साथ में समझाया था. तो मेरी और मेरी फैमिली की सहमति के बाद मेरा किडनी का ट्रांसप्लांट हुआ. उसके बाद अभी मुझे लगभग 1.5 साल हो चुका है ट्रांसप्लांट के बाद. अभी मैं स्वस्थ हूँ और मुझे किसी प्रकार की कोई समस्या नहीं है.
Thank you, sir. Thank you for patiently hearing. So that's the stories we will keep motivating us and keep moving forward. Thank you all the esteemed panelists for sharing your wisdom. Of course, it will help us to move forward and move break the barriers and move to the next things. Thank you very much.
Congratulations, Amol, for bringing up DCD, showcasing it so nicely with the successful recipients with us. Thank you.
Thank you, madam. Thank you, Amol.
Doctor.
Thank you, Dr. Zirpe.
Dr.
Thank
Srishti,
you,
you are
Dr.
mute.
Ashish. And thank you, Dr. Yash.
Thank you, sir.
I would like to thank
Ah,
everyone for joining today, and I would request Dr.
Srishti, special
Manish
thanks.
Balwani to please conclude the session by the vote of thanks. Thank you.
Yeah, thank you, Dr. Srishti. So, on behalf of both societies, ISOT and ISCCM, I would like to thank all the panelists for sharing their wisdom, knowledge, and I would like to thank especially Dr. Yash and Dr. Amol for moderating the session so well. With that, I would like to thank all the participants also for joining us in this evening, and I would like to conclude this session with a important note of Dr. Amol, which said that no organ should be wasted.
Very nice.
That's true. That's
Very
true. All right. Thank you so much, everyone. We'll
Thank you.
conclude for tonight.
Thank you,
Wish you
everyone.
all a very happy evening with the
Thank
family.
you.
Thank you,
Thank
Dr.
you.
Srishti. And thank you, ISSM team. Thank you, everyone.
Bye-bye,
Bye-bye.
ISCCM and ISOT.
Thank you, madam. Thank you,
Bye
Thank
bye,
you,
everyone.
ma'am.
ma'am.